Welcome to Face Forward, the podcast, the series that takes you behind the scenes of the riveting world of clinical trial management. I am your host, Valerie Coveney, and I am thrilled to be your guide on this journey through the nuances of planning, executing, and navigating the clinical research landscape. Today's quite special as we are joined by our Chief Executive Officer and Medical Director at Innovaderm, a company he pioneered in 2000 dedicated to the advancements of research in dermatology. Join us as we dive into placebo responder rate in atopic dermatitis. We will be exploring three crucial points in our discussion: key considerations, ensuring a reasonable placebo response, and finally, how to interpret higher than expected rates. Let's extend our warmest welcome to Innovaderm's founder and CEO, Dr. Robert Bissonnette.
I'm very pleased to be here.
Let's dive right in. So talking about placebo responder rate in AD, what should our listeners be mindful about?
Placebo response rates in dermatology depend on several factors, including the indication itself, the mode of administration, the primary endpoint, and the experience and, I would say, ability of the assessor to perform the assessments. So let's talk about these four factors first, because there are others. In terms of indication, it really varies a lot. So for example, if a study conducted in basal cell carcinoma, the placebo response rate will be very low because the primary endpoint is usually the absence of residual tumor on an excised area. It is read centrally, and this is a very objective measure. For a stable disease, like an inflammatory disease like alopecia areata, for example, the placebo response rate is also low because the disease is fairly stable and the evaluations are not so difficult. Atopic dermatitis is completely different. It's a fluctuant disease. Many patients have flares, and the evaluations are not that easy. So it should be expected that the placebo response rate will be higher than other indications in dermatology. Mode of administration is something that is really important. All dermatologists know that a good ointment or a good moisturizer cream without any medication is not really a placebo. It's an active treatment for atopic dermatitis. So in studies that are conducted in patients with mild atopic dermatitis that are treated with topical products, most of the quote-unquote placebos are actually active treatment vehicles. Primary endpoint is important. In atopic dermatitis, this is usually either IGA or EASI, and as I said earlier, both are fairly difficult to perform. There are challenges in terms of evaluating body surface area. If lesions are mild or almost clear, not always easy to see the distinction between normal skin and disease skin. There are also challenges in patients with skin of color. If dermatologists are not used to see and evaluate those patients, then it's not that easy, specifically because erythema is difficult to evaluate. And finally, ichthyosis and xerosis are easily seen, specifically on darker skin, but they're usually not included in atopic dermatitis evaluations. Excoriations could also present a challenge, not because they're difficult to see or difficult to evaluate, because in some of the endpoints, they're included, like EASI, and in some others, like the VIGA-AD IGA scale, they're excluded. And finally, last but not least, evaluators. So it's really important to work with investigators that have previous experience in research in atopic dermatitis. Ideally, if the investigator is using in their practice some of the endpoints, so if the primary endpoint is EASI, and the evaluator is using EASI on a regular basis because where he or she practices, this is required for insurance companies, for example, the quality might be higher. It takes time to learn how to do a good, easy evaluation. Something else that can also be done from a CRO sponsor perspective is to monitor internally changes in EASI and IGA to make sure that they do make sense. And if they don't make sense, or if there are discrepancies between BSA, IGA, or EASI, to be able to go back to sites to try to understand what's going on. Is it an issue of the PI or the assessor who did not understand the training? Are there other issues? It's important to do this during the study and not at the end of the study when you're stuck with all the data that has been cleaned and final. And all this to say that some sites are really, really good at evaluating atopic dermatitis and others are not as good. So it's important, when possible, to work with sites that do this very well.
Okay, so what could be other factors involved in placebo response in AD?
Several other factors are important. Among those factors, I would say one that is very difficult to control, but very important, is patient adherence to protocol restrictions in terms of concomitant treatments. Most studies in atopic dermatitis will allow patients to use moisturizer creams, but no other active treatments. We all know that the disease can be very pruritic. It can have a huge impact on quality of life, a huge impact on sleep. We know that most of our patients have tubes of active medications at home, so probably some patients do not follow those restrictions and may be using medication at home. Another important question or issue is to make sure that patients that are included have the proper diagnosis. It's not very easy to make a diagnosis of atopic dermatitis, specifically when it started in adulthood. We use criteria, but they're not always easy to apply. And I've seen, as a CRO person, cases where patients were included at sites where when I reviewed photos, out of 5 or 6 patients, I was not convinced that most of these patients had atopic dermatitis. It's possible to have atopic dermatitis where the worst lesion is located on the lower leg, below the knee. However, if this is the case for all patients, then one would say, is this really atopic dermatitis or stasis dermatitis? And finally, a well-known factor is patient baseline severity. So if we include mild patients or if we include patients with low BSA and low EZ, placebo response rates tend to be higher.
Okay, so shifting the focus on the sponsor's perspective here, what can a sponsor do to ensure a reasonable placebo response?
This is a very good question. And I would say that at first, we need to think about what is reasonable. So what would be a reasonable response in an atopic dermatitis study where the primary endpoint would be change from baseline in EZ? Would 60% be reasonable? Most people will say, wow, this is super high. There's an issue because most studies, they don't have 60% change from baseline at time of primary endpoint. Is 0% reasonable? I would argue that it's not reasonable because we know with time, patients tend to get better because it's a disease where you often will include patients flaring at baseline and screening. Few studies, no studies I can remember, have a 0% placebo response. So something in between. We want a trial that is representative of the real safety and efficacy of the product under study. So 60% is probably not good because you have very, very little leeway to show a difference between active and placebo. And 0% is probably not good as well because if the same situation applies to the active, then the effect size that will be measured will be lower than reality. One needs to have realistic expectations. As I mentioned before, patients with mild disease, for example, 1% BSA with a PG of mild, treated with a topical drug, the placebo response rate will be significantly higher than in a moderate to severe BSA 10, EZ16 plus study with the systemic medications. What is important is to try to avoid the extremes. So we don't want 0, we don't want 60, we want something that is true representation of the efficacy of both. And the ways to do this would be to include sites with extensive experience in conducting studies in atopic dermatitis, sites that are used to do these evaluations, include sites with a proven track record of good quality efficacy evaluations, and CROs and sponsors that are often active in dermatology will tend to know which sites, at which site the quality is really good. The CRO or the sponsor should also systematically monitor during the study changes over time in these efficacy evaluations to identify outlier sites, to identify sites where, as I mentioned before, the evaluations don't make sense. Use of photography can help as well. So in doubt, one could look at photographies. The issue with atopic dermatitis is that it's not an easy disease to photograph, but if we ask sites, for example, to take photos of the most severe area, and systematically, when photos are reviewed in a study where patients need to be moderate or severe, if systematically photos suggest severity of almost clear or mild, then we probably have an issue.
So on to our final point of the discussion, Dr. Bissonnette, how would you interpret a study with a higher than expected placebo response rate?
So this is something that we do see every once in a while, specifically when the study is small. If the sample size is small, the chances of ending up with a higher than expected placebo response rate are higher. This doesn't really mean or necessarily mean that the study has not been well conducted or that the evaluations were not well done, because as I mentioned earlier, if a few patients are included at the time of flaring, a few patients are using prohibited medication at home, you may end up with a high placebo response rate in a small study. So when this happens, what can be done? It's really important in a proof of concept study to try to understand the higher than expected placebo response and try to analyze in order to conclude if the medication works or not. So specifically, phase 2A studies, phase 1B studies, this is key because if we think the medication is effective and is safe, then the medication will probably progress to a later phase study. If we think it's not the case, then studies may be stopped there. There are a few things that can be done. One is to conduct sub-analyses. So post-hoc sub-analyses, for example, if we have evidence that issues come from data generated from one site or a few sites or a country, one could do post-hoc analyses excluding this site or this country. If we think it's related to the fact that some patients with very mild disease or lower BSA were included, we could do an analysis excluding those patients. I'm not a big fan of this approach because by cherry picking what you want to exclude, you increase your risks of type 1 error. Another way of looking at it, and this is what I like to do myself, is to also consider other endpoints that are not evaluator dependent. And these could include quality of life questionnaires. It could include biomarkers in the skin, biomarkers in blood. And we've often seen as a CRO that biomarkers on skin biopsies or tape stripping in atopic dermatitis are more sensitive than visual evaluation of the disease, such as IgA or EASI. And finally, one of my favorite is pruritus. So usually when there's an improvement in atopic dermatitis, there's also an improvement in pruritus. So for example, if a small study has a high placebo response rate and the difference between active and vehicle or placebo is not statistically significant, but different, we think that the drug may work, then I like to look at all the other endpoints. And if the biomarkers, the pruritus, the quality of life all go in the same direction and sometimes could be statistically significant, then the drug probably works. And it's worth pursuing studies with the product in a larger sample size where we expect a more normal placebo response rate.
Excellent. So thank you so much. This concludes our conversation for today. Thank you for being part of this project, Dr. Bissonnette.
Thank you again for having me.
As we conclude another illuminating episode of Face Forward, we find ourselves at the crossroads of science and progress. Remember that behind the jargon and statistics lie stories of unwavering commitment, meticulous observation, and the pursuit of evidence that shapes our understanding of health and disease. Stay at the forefront of knowledge and innovation and follow Face Forward on your preferred platform. My name is Valerie Kovney. Thank you for joining us. Until next time.